Hi, my name's Shirley and I'm going to present to you the SHIVERS study which we did comparing the respiratory virus burden among the infants, which is under ones, across the emergency care and our inpatient setting in Auckland. And I'd like to thank our other contributors. My role was as the nurse coordinator, and I worked as part of the team that collected the data. But I'd also like to make special mention of the Tupu Fund, which Adrian received as a recipient, and we used that to actually start off the study. And we got further funding from other sources to complete several more years afterwards, which I don't have all that data yet. So as a background, we know that acute respiratory tract infections are the leading cause of hospital admissions and the attendance to an EC department. The Southern Hemisphere Influenza and Vaccine Effectiveness Research and Surveillance Project, which we commonly call SHIVERS, was a 5-year prospective population-based respiratory virus surveillance that we did on admitted patients, and this provided us with the opportunity to compare the visit rates and the risk factors in these settings. Out of the US, there's quite a lot of data that says that influenza, you're more likely to be admitted if you're under 6 months. And there's very little data on the EC burden for this defined population that we looked at. So our aims was to look at all infants infants under 1 that presented to the Kids First EC in 2014 and 2015. We wanted to estimate the respiratory viral burden. We wanted to estimate the risk factors for admission with acute respiratory infection. We wanted to estimate the respiratory viral burden for non-respiratory, but I'm actually not going to talk about that because I haven't got all that data. And we wanted to assess whether rhinovirus is a predictor for admissions in under 6 months. That's actually Adrian's baby. It's one of his ones he likes. So how did we do it? Well, during 2014 and 2015, we took a 10-week peak winter season from July the 1st to September the 14th. And what I did was we put a nurse in the emergency department from 1 to 9:30 every day, and that took samples for 7 days a week for that 10-week period of all children that presented with acute respiratory infection of those that consented. We looked at demographic and clinical data. We've defined the low socioeconomic group as being quintile 4 and 5. We classified them into SARI versus non-SARI. In the SARIs, the definition was based on the World Health Organization, which is based on whether there's a cough and a fever over 38 degrees Celsius, and it occurred in the last 10 days. And we took nasal swab samples and tested them for influenza, RSV, rhinovirus, and adenovirus using real-time PCR assays, which the ESR did for us. We also looked at the specific viruses that we actually found and the hospital numbers during that 10-week period, and then we calculated them up so that we could get a 24-hour period for data analysis. And we also used the rates that were calculated using the CMD birth cohort for 2014 and 2015, and logistic regression was used to explore these risk factors for admission. So in this table, it shows the first 2 columns. These ones are actual data that we collected. So we enrolled 1,085 children, of which 679 got admitted. And as you can see, the cohort of 6 months and under and 6 months and over is actually quite even based on that cohort. But if you were, oh, it's not going to do it for me. There, you're more likely to be admitted if you're under 6 months of age. We can see that we've got a predominant Maori and Pacific Island ethnicity group, and again, we're very much in the low socioeconomic group that presented to the emergency department. Now, the viruses were calculated for the whole lot. So if you look at this, under 6 months of age, you're more likely to be admitted if you've got RSV and rhinovirus. Whereas if you're over 6 months of age, you're more likely to be admitted with influenza and adenovirus. This one rates the attendance of admissions per 100,000, and again it emphasises that under 6 months you're more likely to be admitted with RSV and rhino, and again over 12 months. But what's quite interesting here, oops, I've gone back too far. Maori and Pacific Islanders are represented right across all the viruses, as we know. But if you look high at the low socioeconomic areas sector, you'll notice that in the RSV, there's actually quite a high percentage of children from the high socioeconomic areas. So when they do present, they actually do get admitted. And that the other interesting fact is that rhinovirus is very evident in the low socioeconomic areas, not in the high. So this is a odds ratio risk for admissions. So you can see that if you're under 6 months, you're more likely to be admitted. If you're Maori and Pacific Islands, you're more likely to be admitted. But low socioeconomic is not a factor, a risk factor for admission. If you, SARI is an indicator but not a strong indicator for admission. Influenza, you may be admitted or you may go home, but if you've got RSV and adenovirus, you're more likely to be admitted into hospital, and rhinovirus, you're not likely to. So in our comments, I'd like to say patients seen and discharged from EC have a substantial virus burden, that the health burden is very predominantly illustrated by Maori and Pacific Island children, and the role of RSV and adenovirus is quite emphasised. Influenza infection, we discovered, is different to the US. We actually have you're more likely to be admitted if you're over 6 months in our hospital. And rhinovirus, unfortunately, is not as significant as a pathogen agent for admission, but it predominantly affects the low socioeconomic population. And the key message we'd like to say is that we would like to have influenza vaccine compulsory for pregnant mums to protect their babies and to protect themselves. We'd like it to be free for children under 5. And we would love an RSV vaccine since it's predominantly around, and we're actually working on the study of that at the moment. Thank you.